morning, everyone. Welcome to another CME lecture organized by the Candy Society of Medicine. Before we go on to the lecture, I would like to make one announcement that is about our annual academic sessions. We're going to have it as a hybrid uh, session on from 7th to 9th of April. And I hope there are many good program with many international speakers as well. So I hope you all will join and keep the dates free. Coming to today's program, uh, I would like to introduce you to the speaker. He's my friend and senior colleague, Dr. Neranjan Dissanayake. He's the consultant pulmonologist at District General Hospital and District Chest Clinic, Rathnapura. He will be talking to us today on asthma in athletes. So I would hand over the podium to Dr. Neranjan.
How can I use a pointer? This point is working. This arrow is working. Yeah. Okay. Good morning, and thank you very much for being here. And I would like to thank the KSM, especially Sumedha, as well as Dr. Madhagadra, my mentor, for inviting me for this lecture. And today I will talk about exercise and asthma, or asthma in athletes, because of a significant thing that happened about 4 weeks ago. Basically, I was asked to discuss about three important things in asthma: obesity, pregnancy, and exercise during a webinar from our college. And when I went through the literature on exercise and asthma, I understood the amount of work that we have to do in Sri Lanka to make doctors aware about this condition, as well as improve our athletes' outcomes so that they can compete better at international levels. And I'm incredibly happy that we have passed out the first MDs in sports medicine who will become consultants in 1 or 2 years time, and Asela is here, and hopefully together we can actually improve patients or the athletes performance levels that will be in par with international standards. Now, when we talk about exercise and asthma, there had been, we basically, when we try to exert ourselves physically, we feel breathless. That is a normal phenomenon that we have. So any person who goes out of his comfort physical zone, depending on his physical fitness and the training that he or she has, will feel symptoms that might suggest respiratory distress, or we can attribute them to the respiratory system. Hence, most of these exercise associated symptoms has been defined as exercise associated respiratory symptoms, or exercise associated respiratory respiratory presentations. Now, when we look at these presentations, what we see here is we see basically 4 respiratory presentations that can come, that might indicate that the symptoms might be due to a respiratory etiology that is the underlying cause. So the first one is shortness of breath, obviously, where you will have narrowing of the airways, causing increasing resistance and increasing work of breathing, perceived as shortness of breath. And you will agree that from simple anemia to ischemic heart disease and hyperventilation and anxiety even can cause these symptoms, but it is rather non-specific. Wheezing seems to be a little bit specific for a respiratory origin, where it indicates a narrowing of the airway to a significant level, where you will hear an audible sound coming through the lower airways of the lung. But even in certain cardiac conditions and even certain interstitial conditions, you can have narrowing of the airways. Hence, it is also rather non-specific. Cough obviously can happen in any patient who has respiratory symptoms, but again, you will understand that this is not a very specific sign for respiratory underlying diseases or symptoms. Chest tightness, again, because of the increasing of work of breathing with the pressure and the tension of the thoracic wall, you can feel a chest tightness, but it might indicate ischemic heart disease, angina, or any other condition that is underlying. Hence, what I want to suggest is that even though the most commonest presentation when we exert ourselves outside our comfort zone is respiratory, can be attributed to respiratory in origin, but these symptoms and signs might not specifically indicate that the respiratory system is the culprit in these patients. Since we have to think about other objective features to see whether this patient's respiratory system is the source of this distress, the shortness of breath, the wheezing, the cough, and the chest tightness. Now, when we look at the athletic trainees, I think my sport medicine colleagues will agree, we train them for a long time, they, especially the elite athletes. So the musculoskeletal system is trained, the cardiovascular system is trained so that they can endure significant amount of physical and mental stresses during their performance. But I think the respiratory system, the lungs and the airways, you really can't enhance its performance up to a certain extent. Hence, that might be a limiting factor in certain athletes, even though how much you train yourself to do things that you do best, right? So when we look at this objective evidence to see whether this patient is having these respiratory symptoms because of the symptoms because of the respiratory etiology, there were several names and things that we have to understand. One is exercise-induced asthma. Now, earlier we used the name exercise-induced asthma. That might indicate that exercise causes asthma. Asthma is a heterogeneous disease which has paroxysmal episodes of shortness of breath due to hyperreactivity of the airway of the lungs. And that is a typical disease, that's a defined disease. But exercise usually don't cause asthma, but it can trigger asthma. But when we call it exercise induced asthma, there might be a wrong impression saying that the exercise is causing asthma. And you can actually see this phenomenon, especially when you're having dealing with small children, where mothers and fathers are afraid to allow the child to play, thinking that they will get asthma because of because of the exercise. But they can't understand that it is because of the poorly controlled asthma. Hence, now this word exercise-induced asthma is now not recommended to be used in the day-to-day practices. Now, what the American Society of Allergy and Asthma and Immunology is suggesting is a beautiful way. Now, this is different from the European Respiratory Society definition. In the European Respiratory Society definition, what they say is exercise-induced asthma. They keep that word. Exercise-induced asthma is the symptoms developing during or immediately after physical exertion. So they go according to the symptoms, where wheezing, chest tightness, cough, and shortness of breath can be there when you do your normal exercises, especially in the first 15 minutes or immediately after completing the exercise during the hyperventilation period. So when you have symptoms like that, the ERS says that this is exercise-induced asthma. But at the same time, the exercise-induced bronchoconstriction is defined by an objectively defined narrowing of the airway, which has to be shown in a person who is asymptomatic or symptomatic. So the European people are a little bit different here than the American definition, but I think the American version is much practically better than the European version, because this symptomatic analysis might not be the most appropriate thing when we are dealing with the patients. So in the American patients, we have patients with asthma, we have patients with no asthma. So there are patients who have been diagnosed as clinically as asthma. There's a group, and we have a group of patients whom we don't diagnose the patient as asthma. They don't have clinical features to suggest that the patient has asthma. But in both these groups, you can have objective reduction of the airway narrowing. So there will be airway narrowing. At least 10% reduction of the FEV1 is taken as a significant value. So these two groups of patients are different because in the first group, they are asthmatic. And this airway narrowing after exercise might indicate in 90% of the cases that their asthma is not properly controlled. Hence, the management of these patients are different. Basically, we have to optimize the management of asthma in these patients. So those are the group where we call AIB, or exercise-induced bronchoconstriction with asthma. So they have to have a clinical diagnosis of asthma, and they have to have bronchoconstriction that is demonstrated by an objective test, which we'll be discussing later. And the other group, they don't really have features of asthma. They don't have asthma in a clinical diagnosis. But these people, when they undergo a bronchoconstriction test, objective bronchoconstriction test, they show bronchoconstriction. Right? So these people are exercise-induced bronchoconstriction without asthma. So these two groups, I think it's very important to identify these two groups because they probably will represent two phenotypes where when we are trying to manage these patients, these two approaches are rather different. So when you look at these two groups, the first group will contain most of the small children and adolescents who are basically atopic. Right? But the second group, the people who doesn't have asthma but bronchoconstriction, majority of them will be consisted of elite athletes. We will see why they have exercise-induced bronchoconstriction. Majority of them will have uh, actually no asthma with bronchoconstriction. Right. So these are the elite athletes who usually perform at the highest level of competition in this in our in the world. Right. So what do we mean by exercise-induced bronchoconstriction? I think if we follow this graph, there's a beautiful graph where this is the percentage fall of the forced expiratory volume as the first second, which indicates indirectly the flow, the resistance of the airways. And then this is the time during the exercise. So this is 0. So -8 is this patient has had started exercise at 8 minutes. Now in most of these exercise tests, we at least have to have a good amount of exercise, reaching the heart rate, maximum heart rate about 85 to 95%, at least for about 6 minutes, so that the patient will be provoked to have exercise-induced bronchoconstriction. So after 8 minutes of strenuous exercises, reaching ideally 85 to 95% of the maximum heart rate of a person, or reaching 30 times the forced expiratory volume in volume where into in 1 minute, right? 30 into FEV1 in 1 minute. That is the ventilation that they have to maintain for about 6 minutes. When that happens, after stopping the exercise, you can see that just after stopping, there will be a FEV1 be slightly elevated, right? And then this will rapidly plummet. So you can see the post-exercise. The patient is not doing anything. He has exercised or exerted himself for about 8 minutes, stopped the exercise. Now he's basically panting. And then is the time that he will develop exercise-induced bronchoconstriction. And then this patient will be severely symptomatic. This patient will complain of chest tightness. He will develop a cough. He will develop wheezing, and sometimes he will complain of a significantly markedly elevated shortness of breath that is disproportionate to the amount of exercise that he has already done, right? So this is the symptomatic area. Then when you look at objectively in this patient, we will see at least about 10% of reduction of the FEV1 when we do the spirometry values. So you can see that it is dropping, dropping up to about 10 minutes. And then after that, gradually the body recovers. And then this recovery process will take at least for about 1 hour, 30 minutes to 1 hour, unless we take a bronchodilator to relieve the symptoms. So, and the beautiful thing is, after you strenuously exercise and then you provoke a bronchoconstriction attack, there is what we call a refractory period for about 2 or 3 hours, where after, after this strenuous exercise, if this patient again does a strenuous exercise within that 2 or 3 hours, he will not develop this degree of bronchoconstriction, right? That is what we call a refractory period. The theory is that is because there is tolerance to the histamines and the leukotrienes that are secreted during the initial stage. So that it is almost saturated. They can't provoke another reaction because of that, right? So this, I think, graph, if you are trainees in sports medicine or in medicine, I think it's very important to understand this graph properly, because most of the pathophysiology that I will be discussing next will depending on the appearance of this graph, right? So why are we talking about this? Is it common? Is it causing a problem to the patients, right? Now the the Global Allergy Asthma European Network have done a study during the Beijing Olympics in 2000. In Beijing was 2012, right? I can't remember. Beijing Olympics, and what they have found is that about 25% of the elite athletes, these people are the cream of the athletic community, complaining of features suggestive or symptoms suggestive of asthma. So they have respiratory symptoms in them, right? And objectively, when they measured these patients in 2000 and 2004 in Sydney and Athens by the International Olympic Committee, the Medical Commission, they found that when they did the objective testing in these athletes, about 1/4 of them had objective evidence of exercise-induced bronchoconstriction. So they were having symptoms suggestive of asthma, as well as objectively, every one of 4 of them had objective evidence to suggest that the patient had induced bronchoconstriction. So you can understand the magnitude of this patient's suffering. And probably this will also affect the performance of these athletes, as well as developing the anxiety and causing mental stress to these patients as well. So our exposure is probably to our patients, our children who are athletes, and especially some soccer players, cricket players who are there. We have exposed ourselves, so probably some of them also be having this problem within them, provided the fact that even in Sri Lanka, Sri Lanka is one of the highest prevalent countries of wheezing and asthma in adolescents and children, right? So in some people, in elitist athletes, the EIB or exercise-induced bronchoconstriction is about 70%. So some people it's 30, some people it's 70. So there are some defining factors why these wide range of prevalence is there. It depends on the sport that you are doing. So if you are performing at a constant level, where like cross country, decathlons and things and like that, you will be more prone to develop exercise-induced bronchoconstriction, especially if you are doing it in a cold environment. For example, long-term skiing marathons that are there in the foreign countries that are there. We are not exposed to that, but those are the people who will be exposed more towards that. And people who do volleyball, that needs short bursts of activity will have a less prevalence of exercise-induced bronchoconstriction than people who are having long-term endurance. Swimmers also will have a higher degree of exercise-induced bronchoconstriction due to various factors. Now, one of the main factors of these elite athletes is that, so you can understand basically, now when we breathe in, when we breathe at rest, now we are breathing for about 6 liters per minute slowly, right? But when we start to breathe around 35 liters per minute, our air bypasses the nose and goes into the mouth. And these elite athletes breathe about 200 liters per minute sometimes. And you can imagine the amount of sheer stress that they undergo. And especially if the air is pollutant. Though these patients who usually they are like athletes and other people are trained in areas where the particulate matter, the allergen levels, especially in swimming, so the chloramine levels are there in the in the pools. So they sometimes are exposed to high levels of pollutants, and they are taking a lot of air inside into their lung. And at the same time, because they train in groups, these people are prone to get lower respiratory tract infections, hence damaging the airway further. So all these factors will contribute together with the environmental temperature as well as the type of sports that they do will contribute to the higher rate of exercise induced bronchoconstriction in elite athletes or higher level athletes in our community. Right now, that is about the elite athletes. Now we are worried actually about the children as well. Now there are children coming to me as a pulmonologist, and the most important factor in these children that we notice is that these children are not allowed to play. They are not allowed to go out and play. And sometimes when these mothers and fathers or parents don't allow them to play, it will not only affect the physical fitness of that child, it will definitely affect the psychological development of these children. Because, for example, in a class, friends ask them to come and play cricket with them. Mother is preventing that. It can cause two problems. One thing is, he will not develop that good relationship, interpersonal relationship with the other children, which might affect significantly detrimentally in the adulthood ages. And the second thing is, when he is, in a side, and when they know that the patient is asthmatic and they are not coming to play, usually he will be gradually not be a part of that class, and that will affect that psychological development of that child. And it has been proven that exercises and sports not only improves the psychological aspects of children, it improves the lung functions, especially in asthmatic children. When you are doing exercises, it will improve the lung functions, it will reduce the inflammation of the lung, and so on and so forth. So if we are not allowing these patients to basically uh, uh, play, that will be a huge problem. And when you look at the prevalence of exercise-induced bronchoconstriction, now in patients with asthma in our children, right, about 40% of them will have exercise-induced bronchoconstriction. And the important thing is that in some certain groups of children, they don't have underlying asthma, and about 10% of our children will have exercise-induced breathlessness and wheezing, but underlying they don't have asthma. So this is the group that we have to identify and try to manage. Okay, so because now some of them probably might have undiagnosed asthma, because when we do studies, most of them have a history of maternal or paternal asthma, most of them have a history of atopy, most of them will have allergic rhinitis. So probably from this 10%, we probably have a certain group of children who are not actually diagnosed as asthma, even though they have asthma, because asthma is a clinical diagnosis. But there is a certain group of children who doesn't have asthma, atopy, or anything, but they have objectively proven exercise-induced bronchoconstriction, which pathophysiologically is different from the asthma that is commoner in children in that age group. So important two groups are there: elite athletes as well as children who have this problem to a certain extent. Now, why do we have this problem? Now, there are various theories. Why do, after exercises, why do patients or people get constriction of the bronchi? So there are various theories about that. Now, one of the theory that is usually accepted is the osmotic theory. Now, as I told you previously, when we exert ourselves, we breathe in and out a lot of air. Sometimes we bypass, almost all the time, we bypass the nasal cavity and we breathe from the oral cavity. When we breathe from the nasal cavity, the humidity as well as the temperature will be higher. But when we breathe from the oral cavity, the humidity will be very low and the body will not have enough time to bring the air's temperature back up to the normal body temperature. And so there are two theories, the heat loss theory as well as the osmotic theory, which osmotic theory is the one that is now accepted, where when you breathe in and out, what happens is, because of the low humidity, we have a usually amount of water in the airways, and this airway water is evaporated. That is the one that you can see here in the graph. So when we look at when we look at the water loss, you can see that the water loss is significantly rising. So there will be a rise in the water loss, and when there is a rise in the water loss, you can see a corresponding drop in the FEV1 as well. So as the water is lost from the airway, you have a objective reduction of the forced expiratory volume. Why does this happen? The reason that they are postulating is that when you have the water evaporating, the osmolality of the surrounding fluid will increase, and this will cause outpouring of water from the epithelial cells and the bronchial cells. And when you have this dehydration that is happening in the cells through what we call aquaporin 5, these are water channels, there will be there will be destabilization of cells. So when this dehydration happens, we have mast cells, right? So we have mast cells. In those mast cells, we have preformed histamine that is already there. And then this histamine is released outside. And we know that histamine is a potent vaso and smooth muscle constrictor, right? And the other thing is, when this dehydration happens, the enzymatic cascade induces the formation of cysteine leukotrienes. This name is very important because when we are talking about therapy, this name will come back again. Cysteine leukotrienes that are formulated as well as prostaglandins. Right? So because of these two substances, the chemical substances that are triggered or secreted by the mast cells, which are dehydrated, there will be a bronchoconstriction that will be there. Other than that, these cells or these substances will stimulate various nerve fibers that are there, sensory nerve fibers that are there in the bronchial epithelium and the subepithelial layers. And they will secrete what we call neurokinins. Kinin means to work, neuro means from the nerve. So these neurokinins, like neurokinin A, peptide P, will cause a further increase of mucus secretion as well as bronchoconstriction. Right? So this is the pathological pathway that they think that causing the bronchospasm. This is very important to understand, because when we start to treat patients, understanding these pathological underlying features as well as the substances that are involved will help us to manage these patients properly. The important thing is, you will not see a significant amount of eosinophilic inflammation that is there usually in asthma. Right? So now, this study in 2005 beautifully explains that. Now, this is a mast cell. This will secrete preformed histamine as well as tryptases. These are preformed granules that are there in the mast cells. And at the same time, because of the airway stimulation, it will start to synthesize cysteine leukotrienes and prostaglandins, which might be the cause for the prolonged bronchoconstriction that we see after an initial exercise attack, right? And they have shown that the rising of the histamine and the tryptase in a graph corresponding with the drop in the FE1 to FE1 ratio. So objectively also, the histamine and the tryptases corresponds with the FEV1 drop, suggesting that our hypothesis might be a correct one, right? But medicine is not simple, isn't it? Right? Because now in medicine or in any topic, we have endotypes, we have phenotypes, right? So because that is the thing that we call one thing doesn't suit for all. So hence now they have identified certain phenotypes in exercise induced bronchoconstriction, and that might have clinical implications on how we treat this group of people, right? First is the normal thing that we know. In your left, in the arrow, you can see the two theories that I told you about: the water loss, then the hypoosmolar environment, cell shrinkage, and then modulator release. So the mediator release. So that is the pathway, the osmotic pathway that is now accepted as probably the most important thing or the accepted thing. But other than that, there was what we call the thermal mechanism, because they noticed that especially in athletes in doing this cross country skiing at about minus 20 degrees Celsius, when they are working or when they are walking or when they are exercising themselves, they have noticed that they have a high preponderance to develop exercise induced bronchoconstriction. So the theory was that when you breathe in cold air, there will be a narrowing of venules, and when you start breathing normal air and when it is rewarming, these venules and the other vessels will be dilated, and because of that there will be increasing amount of extravasation of the fluid, and then this will cause bronchoconstriction. But it probably has a component about 10 to 15% to the bronchoconstriction. So the major component is because of the hyposmolar theory. Right. Now, on top of that, recently in 2018, this is a beautiful article I can share with you if you want to, explains about 4 or 5 other mechanisms that can coexist with this mechanism. One such mechanism is the enhanced T2 response. Now, we know in bronchial asthma, we have a T2 response. T2 response is that these lymphocytes secretes interleukin 4, 5, and interleukin 13, compared to a T1 response where you can secrete interferon gamma, interferon gamma, interleukin 1, 2, right? So usually T2 response stimulates a eosinophilic and an IgE mediated inflammatory response. So what they have noticed in these elite adults is that even though they don't have an atopic history or asthma history, after these patients have undergone significantly heavy exercises for about 3 or 4 years, their genetic predisposition or their immunologic predisposition is more towards a Th2 response rather than a Th1 response. Hence, these elite athletes who were previously well, now probably are becoming more atopic because of the exercise and the physiological changes that are there. There's a beautiful study done in Italy, right? Italy are for about 14 years, and they have objectively proven that they have increasing amount of atopy after that. Okay, so that is one theory that is there. And the fortunate thing is that this Th2 type of asthma and the bronchoconstriction will usually respond to corticosteroid inhalation, unlike the neutrophilic inflammation that is associated with the other parts. Right? Now here, the second one is the bronchial epithelial injury. Now there are 2 basic ways you can have, 2 or 3 basic ways you have bronchial epithelial injury in elite athletes. One is that I told you that they are more prone to get viral and bacterial infections. Second thing is that they are practicing in cold, harmful environments that might be harmful and damaging to the lung, and at the same time they will be exposing themselves for a significant amount of air containing various abnormal or harmful substances, like the chloramines chloramines in swimmers, particulate matters in athletes, and allergens as well in indoor sports as well. So these people will have increasing amount of damage, and when they study these patients, they have noticed that it is a neutrophilic inflammation that are there. It is interleukin 8 that is secreted, not the Th2 interleukin 4, 5, or 12. So now you can understand the pathophysiology is different, and these people are naive to corticosteroid therapy. So these patients will not respond to inhaled corticosteroids if we don't understand this pathophysiology. Right. The third group is that the small airways. Now, even in bronch asthma, we are thinking about the radial medium airways, but we have the bronchioles far away from the bronchi, and these are stretched and narrowed during severe exercise, and this sheer damage caused by this is postulated as a cause of bronchial hyperresponsiveness or bronchial constriction in these patients. So when they examine the urine and the serum of these athletes after a strenuous exercise, they see proteins like CCL6, which indicates damage to the small airways of the lung. Right? And the other important thing is that we know that as sports people, usually a sportsman will have a low blood pulse rate, isn't it? The pulse rate will be around 55 to 60 in most of these. The reason is that because they are too much, targeted for sympathetic activity, their parasympathetic activities also will be high. And when the sympathetic activity is not there, there the parasympathetic tone will be maintained at a higher level. So there will be a bradycardia in this patient, which is normal in a normal sense. Right, like that, because these patients are significantly going through severe exercises and stresses in the normal day-to-day environment, the vagal tone will be higher in these athletes. And we know that there are two receptors in the muscle that is important in the bronchoconstriction, the muscarinic receptors, the M3 receptor, as well as the beta adrenergic receptors, right? So when the muscarinic receptors are OX, are hyperstimulated, you will have a baseline based bronchoconstriction at the baseline. And these patients will probably not respond to the adrenergic bronchodilator that we give, like salbutamol, but they will respond to ipratropium bromide, right? So that's why some people will not respond and some people will respond. So these are called the phenotypes of the exercise induced bronchoconstriction. So it's really, really interesting, so that if we can identify this pathophysiological basis of each and every individual, we can tailor the treatment appropriately so that they will be able to maximally enhance the performance in their day-to-day functions. Now, nothing is because of environment alone. There are other factors that contributes to the bronchial constriction. One is the genetic predisposition, right? So this is a beautiful study where they have shown that transglutaminase 2 is increased in bronchial airways in patients who are predisposed to exercise-induced bronchoconstriction. So they have a milieu or environmental chemical milieu in their bronchi that will, help bronchoconstriction or facilitate bronchoconstriction. Why is that? Because they have increasing amount of genetic material or transcription of genes, especially when they undergo exercise. These people have inducible genes in the cells that can promote bronchoconstriction. So you can see that some of these genes are forming tryptases, which is a constrictor. Some of them are to do with the chloride channels, right? Some of them due to the mucin. So we know that one of the causes of bronchoconstriction is increased mucin secretion. So there is a genetic predisposition of these patients to develop endobronchial constriction. And one of the other one is the mutations of the aquaporin 5 gene, which is there in the epithelium, which has to do with something to do with the water balance in the airway. Okay, how can we diagnose these patients? Will they come to us saying what, or when they come to us, do we have methods of diagnosing, right? Unfortunately, now usually patients come to us with a symptom, isn't it, as a problem. But when we look at the data, what they see is that, yes, when the patient comes to us with exercise-induced asthma, they have a probability of having exercise-induced asthma or exercise-induced bronchoconstriction. But in a majority of patients who don't come to us with symptoms or don't complain of symptoms, when they are objectively tested for bronchial constriction, they have evidence of bronchoconstriction. So almost the symptomatic and the asymptomatic people, when we take as two groups, they have the same prevalence of endobronchial constriction, exercise-induced bronchoconstriction. Okay, so that's a very important fact, because now these people who come to us, we can help them, but the people who don't come will suffer, and probably they will not feel a significant amount of symptoms, or they will be probably withstanding them, but their performance level will be lower than what they can maximally achieve. These patients probably can do 100 meters in about 10 seconds, but now they are doing it around 10 to 12 seconds, right? So, but 0.1 second is important in athletics. So sometimes these patients might not perform as they should be. So this is the most important thing that we have to understand, because some of these athletes will not have symptoms, right? So some of them will be asymptomatic. And this is a beautiful study that they have done, right? So that is why, especially in the exercise-induced bronchoconstriction update in 2016 by the American Association of Allergy and Immunology and Asthma, this is a beautiful update which I can share with you. So a diagnosis of EIB, exercise-induced bronchoconstriction, should be confirmed by demonstration of airway reversibility with a challenge in associated consistent with EIB. Now this is for patients who are not elite athletes, right? But for elite athletes, always we have to do an objective testing in all of them. So in a patient, for example, our cricket team, right? Anyway, they are not fit anyway, right? So, but anyway, because before we send them off, we ideally we have to do a bronchoconstriction test to identify why they are not performing well. Maybe that is the reason, not because they are playing for money. Okay, so we have to empathize with them, right? So that is the important thing that we have to think about. So these elite athletes should be assessed with a probable bronchoconstrictor test, right? Right. So what are the tests that we can do? So there are two types of tests that we can do. One is the direct challenge test, and other ones are the indirect challenge test, which can be exercises or surrogates. Now, with your knowledge about the pathophysiology, we can understand the direct challenge test. Now, in the direct challenge test, what we do is we make the patient inhale a substance, right, which can directly bind to a receptor at the bronchial airway, so that they can have a narrowing. Right? We use two substances like that. One is methacholine, other one is histamine. So it is basically a direct challenge that we do. And we usually see the percentage of FEV1 drop and the concentration that we had to give to get that drop. And then you can say whether this patient has bronchial hyper-responsiveness or not. Okay, that is the first thing. The second thing is the indirect challenge is that we don't directly challenge that, but we create an environment that is similar to a person who has exerted him or herself to the maximum level according to criteria. So I think you can understand that this is one of the better methods, because we are creating the environment exactly that is there after an exercise bout, right? So there we can use exercise per se in a controlled manner, which I'll be going into a detail a little bit, right? So we can ask the patient to exercise and then monitor the FEV1 objective, right? And the second thing is, we know that when the patient exercise and hyperventilate, what happens? There will be an abnormality in the osmotic milieu of the airways. So if we can create that osmotic gradient inside artificially, then that will be the best. So we can use mannitol for that. So we can use mannitol inhalation for this patient to create that osmotic change in the air. So that is why we call it is exercise and surrogate. Surrogate means someone other than that, right? So this is about the airway hyperresponsiveness. This beautiful smooth muscle can be triggered to this one without any provocation, but with a minor provocation. Okay, there are enough examples for that, especially for males living with a wife. Okay, so basically, right, so this is what we do. We measure the percentage decrease of FEV1, and then we give the methacholine dose. And when it cuts the certain level, then we measure the volume or the concentration, and then we can say whether this is the patient is hyperresponsive or not. So if a patient is not hyperresponsive, airway hyperresponsive, then it will be something like that. However, we give methacholine, there will be no significant FE1 drop. But if there is a hyperresponsiveness in the airway, there will be a higher FE1 reduction. And this can be seen especially in patients who are having underlying asthma. Okay, so this might be a good diagnostic test to diagnose asthma, right? But it is not a good test to diagnose exercise-induced bronchoconstriction. I will tell you why. So basically, the standardized exercise challenge test is that we usually expect a more than 10% drop in the FEV1 after this patient has exercised to 6 to 8 minutes. At least 6 minutes of significant exercise should be there. What is significant exercise? You should reach the about 90%, 85 to 95% of his maximum heart rate. You know how to calculate the maximum heart rate, isn't it? It's 220 minus age, but there is a now new calculation, 208 minus 0.7 into age, isn't it, right? Whatever the thing that you use, you can calculate the maximum heart rate, and then you can at least achieve the 90% mark, and it should be maintained for about 6 minutes. The important thing is that. So you have to arrange for the ergometer. If you are using ergometer, the resistance should be adjusted, or the If you're using a treadmill, you have to adjust the other thing, right? And the other thing is you have to do it under low humidity, less than 50% humidity, and the temperature should be 20 to 25. So it is a standard exercise challenge test which can be reproduced. And the important thing in this exercise test is that this can be catered to the patient's requirement. For example, if a patient is doing the event at -10, right, then we can actually see whether this patient will have a problem at that time. Okay, so that is a good thing that we can do, right? So it is a very important thing that we can use. This is, if we can do this, that is the best that we can do, but you will understand the problems associated with it. The other one is that eucapnic voluntary hyperpnea, where this is the one that usually the British use before the Olympic. They send the patients to the people to the Olympics, where you inhale, right? Inhale a concentration of carbon dioxide 5% and oxygen and nitrogen. Why we are increasing the carbon dioxide? Because now this patient wants to hyperventilate, right? So if you have to match FV1 to 30 times, so in a minute, you have to increase the amount of ventilation to a significant level. If we are using the normal air, what will happen? The patient will develop respiratory alkalosis within 1 or 2 minutes, and there will be acid-base balance. So that is why we are maintaining the carbon dioxide at 5% in this solution. Okay. So because of that, this patient is taking in an air out, in and out, for about 6 to 8 minutes, and then after stopping that, we measure the FEV1 drop, and then we see whether there are 2 consecutive less than 10% drop in this patient. This is actually a reproducible test if we have the correct equipment, and you will agree that it is not difficult to establish. Right? It is not difficult to establish. At least if we have one center in Sri Lanka, if we can establish, right? When Asela comes, we will establish it in Kandy, right? So that is the thing that we have to do, right? So then our athletes will have a very good, what you call, deal, right? So, and the other one is the manifold provocation test, which I described earlier. So those are the 3 tests that usually there. There are other tests that we have to think about. But the recommendation is that of the bronchoacoustic update is you have to perform a standardized bronchoprovocation test to diagnose EIB, right? So they recommend for a standard EIB test to be performed. The International Olympic Committee Medical Council also recommends that in each and every patient, because if you don't prove that, they will not allow you to do salbutamol, right? Which is a restricted drug. So you have to have a therapeutic use exemption for these patients. So you have to have objective proof that this patient has exercise-induced bronchoconstriction, right? So all elite athletes should undergo this test ideally, right? So in a patient with no clinical asthma, the best is basically a indirect upgraded challenge like exercise or surrogate testing rather than methacholine test. Okay. Right. Now these are the accepted criteria to accept a patient who needs beta 2 agonists, right? So the pulmonary function should be less than 70%, right? Bronchodilator test, you should prove that the FEV1 increases by at least 12% or 200 milliliters, right? So that you can use this bronchodilator. Eucapnic voluntary hyperpnea, you should prove FEV1 more than 10% drop. Exercise challenge more than 10% drop. Methacillin challenge more than 20% drop. And hyposmolar test like mannitol, you have to prove FEV1 drop of 15%. So these are the accepted values so that your athlete can have salbutamol and you can use a therapeutic use exception in that person, right? Because there was a thought that, the airways are there. If you dilate more, you can perform more, right? But they have proven beyond doubt that how much salbutamol that you take, the airways cannot be dilated by after a certain, and there is no actual benefit rather than the side effects of developing hypokalemia, tachycardia, and ventricular arrhythmias, right? Now, this is a little bit of a crowded slide, but I want to give it to you as a whole because it says some very important things. So how can we investigate these patients? We have suggestive patients with exercise-induced bronchospasm or bronchoconstriction. Then ideally, the first important thing is we have to perform a normal spirometry, right? So if the spirometry is less than 70, that means FEV1 is less than 70, right? So that might indicate an obstructive airway disease in this patient. Hence, whether you have to see whether this is reversible or not, right? So in a patient, even with asthma, where FEV1 is less than 70 and it is reversible, that indicates poorly controlled asthma, isn't it? And these patients should not undergo further testing for EIB because it is already proven. Okay, so we have to optimize the management of asthma in these patients, right? Right. So I will go to the other side before coming to this side, right? So if we want more than 70%, right? Still, this patient can have asthma, isn't it? The patients, we know that there's diurnal variation and episodic variation of asthma. Still, again, if you have reversible airway obstruction defined in the IOC as more than 12% or 200 milliliters increase, then we should diagnose the patient as a reversible airway disease. Might not only be asthma, there might be other things. Might have a transient infection or something like that. But we should not do with the EIB because they are having a high risk of provocation, right? Right. So if the FEV1 is more than 70, normal, and there is no beta agonist reversibility, we take 2 puffs of 100 micrograms of salbutamol. That is why we check. Then we have to go for indirect bronchoprovocation testing, right? Bronchoprovocation testing. So indirect bronchoprovocation testing, exercise, standard exercise, EVH, and mannitol. Out of the three, we can use anything. So if there is no airway hyperresponsiveness or bronchoconstriction, then we have to think about the differential diagnosis that can mimic airway bronchoconstriction, which I will be going into a little bit detail later. Because there are mimickers, because I told you in the first slide that even though we take 4 respiratory symptoms, there are many, many mimickers that might come. Some of them will be associated with exercise only, right? And if the patient has airway hyperresponsiveness, we have to go and treat, right? So what are the mimics in if a child? So there are two. I have grouped into two: the mimics in children and mimics in elite athletes. So the mimics in children, obviously, the first one is diagnostic of exercise-induced asthma. These patients will have asthma, right? And the asthma should be controlled. The second important thing, especially in children, mainly in adolescent girls, is the vocal cord dysfunction, right? Vocal cord dysfunction sometimes mimic even severe asthma attacks. There are patients who have put into ICUs because of vocal cord dysfunction, where the presentation is completely different. Where in the vocal cord dysfunction, what happens is there are several types of vocal cord collapse. There can be laryngomalacia, there can be paradoxical vocal cord movements, right? But what happens here is that the vocal cords, usually in inspiration, they move, they abduct, right? But in inspiration, in these patients, what happens is they adduct. Okay, so the airway will be narrowed. So the obvious sound that will be coming is stridor, not wheezing, and it will be emanating from the larynx, right? Larynx. So if you listen to the stethoscope, you will see a monotonic sound mainly in inspiration, not in expiration. Okay, expiration you will see the wheezes, but here you will see the inspiratory sounds that will be the stridor, right? So it will be coming from the throat. So it's very important to understand this, especially in a child with stridor. I will first think about epiglottitis and foreign body inhalation. That is a different thing, right? But if the child after comes with an exercise with a stridor, then you have to think about whether these are vocal cord dysfunction, especially girls, young girls, adolescents, right? The one characteristic feature that will help you to differentiate is that as soon as the exercise stops, this stridor will stop. Unlike the wheezing that you will have in asthma, where it will continue. Okay, that is one way of differentiating that. The gold standard of differentiating is that you have to do a video laryngoscope during the exercise. Maximum exercise, you have to insert a small laryngoscope inside, view the vocal cords, and when the patient is symptomatic, you have to see how the vocal cords function. That is the gold standard. Or else you can use what we call a flow volume loop, where you will have a flattening of the inspiratory loop, which will suggest variable extrathoracic obstruction. Okay, we have the flow volume loop now. It will come like this and this, but if it is flattened in the inspiratory loop, that might indicate vocal cord dysfunction. Okay. Right, exercise-induced hyperventilation, again, very common in children and adolescents. What they do is they disproportionately hyperventilate than what is needed to the exercise. And what happens is that because of that, they will feel a chest discomfort. This is very common in patients who are children who are anxious, right? Especially before exams, Shishatte O level and A levels, most of them will come with no history of asthma with chest tightness and hyperventilation, right? And exercise induced anaphylaxis is another important thing that we have to diagnose at the earliest stage possible because it can be life threatening. And it can be triggered by certain foods as well. But exercise induced anaphylaxis, the patients will have wheezing, obviously, but they will have other features of anaphylaxis like itching, pruritus, and an urticarial rash developing after exercise. Right? So, if a patient with exercise induced wheezing has these features in them, we have to be careful because they will need an EpiPen to be given because sometimes this patient can collapse. Right? They have a low blood pressure as well. Obviously, children and adolescents will have chronic lung diseases like cystic fibrosis, sometimes cardiac diseases. We have to think about that. Right. So, in adults or in athletes, the important differential diagnosis that we have to think about is I discuss about the vocal cord dysfunction. This is the third thing that I would like to highlight. That is exercise induced arterial hypoxemia. Right. It is very common in elite athletes because they breathe fast and they have a huge amount of ventilation. And at a certain instance, what they think is that the intracardiac and intrapulmonary shunts open up. Okay, so intracardiac and intrapulmonary shunts open up, and because of that, when you look at usually when you do exercise, it will come up to 100% saturation, isn't it? That is the most likely possibility in a normal person. But in these elite athletes, you might see a desaturation when they are symptomatic, right? So the possibility is that these patients have intracardiac or extracardiac or extrapulmonary shunt opening when the patient's having a significant amount of exercise. So that we have to do a saturation to see, right? Swimming induced pulmonary edema is another very important thing, and about 15% of the elite athletes will develop this condition. What will happen is that when the patients do significant amount of exercises, there will be fluid because now when you do exercises, the cardiac output will increase. When the cardiac output increase, the way most of the capillary beds of the lung will be involved, isn't it? They will be filled up to the maximum. The hydrostatic pressure will be high, and then in some people, the fluid might slowly leak out, causing pulmonary edema. Common in swimmers, right? Common in swimmers, and they can have pulmonary edema. And if you take a X-ray, sometimes you might see patches of that. And if you do a DLCO or what we call interstitial, what you call this uh, gas exchange study, because these patients interstitial area is filled with fluid now, they will have a reduced DLCO. Okay, usually what you expect in a exercise as a patient is that you will have an increased DLCO, but here you will have a reduced DLCO, right? These are rare but important differential diagnoses that we have to keep in mind when we are assessing these patients, right? Exercise-induced hyperventilation is the one that I talked to you about previously, especially in anxious people. You know, අඩි 10ක් ගිහලා අඩි 100ක් දිව වගේ හති දාන කට්ටිය, right? So අපිටත් එහෙම වෙනවා because we are deconditioned anyway, right? So those are the type of people that will have that, and poor physical fitness, right? Probably very common among us. Okay, මෙතන පඩිපෙළ ටික නැගගත් you will feel breathless, right? So basically those are the things that we have to think about in the differential. There are a lot of things, but I don't want to go into each and every detail. But in children, we have to think about exercise-induced anaphylaxis. That's very important and life-saving, right? And vocal cord dysfunction. In adults, I think we have to think about, especially in elite athletes, we have to also think about VCD, vocal cord dysfunction, but at the same time, desaturation and pulmonary edema. Okay. Now, this is how to differentiate the exercise-induced, laryngeal obstruction with exercise-induced bronchoconstriction, and I explained to it previously how we can differentiate. So this chart, right, is a beautiful chart. I will keep this presentation. So if you want these charts, you are free to copy. There's no issue about it, right? So basically, this is a simplified algorithm and management of exercise-induced bronchoconstriction. So we have a patient with dyspnea, wheeze, cough, chest tightness during or immediately after exercise. So we have that patient. Now we have a suspicion whether this patient is having exercise-induced bronchoconstriction or something else. And here the baseline testing is done. And if the baseline FE1 is more than 70 or 80, you do the indirect test. If it is positive, you manage appropriately. If it is negative, then we have to refer for further assessment about the differential diagnosis. If one is less than 80, the patient is having a bronchodilator response, manage appropriately as asthma, else we have to investigate this patient further. Now, this will basically tell you why these investigations are done and what are the things that we can do. So when the patient is having high intensity aerobic exercises, there is high ventilation with osmotic theory coming in. So the diagnosis is by high intensity exercise or eucapnic voluntary hypercapnia. How we can prevent is that sometimes when you use a mask, sometimes we can humidify the air to a certain extent, right? Transient airway dehydration, you can stimulate that or simulate that with mannitol, right? And then bronchoconstriction, we can stimulate with methacholine and histamine, right? How we can act is that transient airway dehydration, we can avoid airborne irritants or allergens. If there's an inflammatory response, we can use montelukast, chromoglycic acid, or inhaled corticosteroids, short-active beta agonist, and then we can see. And the refractory period is the one, usually what they suggest is to use a warm-up before exercising. So when we use the warm-up, we can get that refractory period into the performance time, right? So that is why we advise athletes to have a good warm-up, especially patients who are having bronchoconstriction before the period of event, before the event, so that they will be in the refractory period when the event starts. So final 2 or 3 slides. This is we can give any drugs. We can give beta agonists, we can give montelukast, chromoglin, we can give even theophylline, furosemide inhalers, but these are athletes, right? Especially when you are prescribing to athletes, it is different from prescribing to a normal layperson, because if the substance is accepted as a performance enhancing substance, then this athlete can get a black mark without him knowing, sometimes without the doctor knowing. Okay, so they do the random samples, urine samples, and sometimes they don't know that they have taken a substance that is not allowed. Right? So, for example, steroids are not allowed, oral steroids at all. Okay, salbutamol is allowed if you have a TUA, right? That is the therapeutic use exception, but you have to take it in a certain dose. Oral beta agonists are not allowed. So oral beta agonists not allowed, steroids are not allowed other than inhalers. But if you're taking a beta agonist, which is the standard treatment for exercise-induced bronchoconstriction, you have to take it in the accepted dose category, right? These are there in the World Anti-Doping Agency. So before we prescribe to asthmatic or a exercise-induced bronchoconstriction patient, we have to consider these factors as well, right? The regulations of the WADA, World Anti-Doping Agency, you can see that most of them are permitted, right? Antihistamines, cetirizine, cetirizine, loratadine permitted. Leukotriene modifiers are permitted, that is montelukast. Inhaled steroids are permitted. Systemic steroid prohibited, right? We can't give at all, right? Beta 2 agonist, maximum dose is 1600, or formoterol 54 micrograms. 54 formoterol is about 9 puffs. And master stabilizers and anticholinergic things are permitted. So, but even though these patients can be managed with the pharmacological management that we give, but I think this management should start at the beginning, at the earliest stages of things. These children should be given a proper sport to do. Some of them have high degree of possibility of exercise-induced bronchoconstriction. So if you identify these patients early, we can advise them to avoid certain sports, and we can ask them to do certain sports. So that is the first thing as a doctor that we can do, right? So for example, that the people who are having a bronchoconstriction should not be advised to do marathons, skiing, and things like that, but they can be promoted to do volleyball, badminton, and things like that. Okay, weight management is very, very important in even from the children's perspective. aerobic exercise has proven that your physical enhancement is more. So because of that, the lung will be able to support you more, because the anaerobic exercises will be less. Anaerobic formation will be less. So if you do aerobic exercises, if you get your body stature up to the optimum level, then the lung, which can't be improved to up to a certain extent, will be helped, and your performance level will increase. Harmful atmospheric substances, especially better to avoid training in areas where there is a congestion, lot of traffic, right? If possible, better not to do that. Very high altitudes, unless it is a prescribed training. Infectious agents, try to get the vaccination, influenza vaccination and the pneumococcal vaccination, so that they will prevent they getting infections during their training periods, right? Cold environments, better to avoid, especially minus degrees. It's not there in Sri Lanka, but it's a word, and warm-up procedures are the important thing. I will not go into the recommendations here. The important thing is beta adrenergic receptor like salbutamol can be given about 20 to 30 minutes before the exercise or the performance. But the important thing is you should never prescribe more than 4 times a week, because salbutamol, when you take alone, can develop tachyphylaxis. That is, it is tolerant, and even when the patient is having a severe bronchospasm or bronchoconstriction after an exercise, it will not work. So hence, if a patient needs more than 4 times salbutamol, it's always better to avoid salbutamol and think about other management options that are there. But if a patient who has, not regular bronchoconstriction, then you can use salbutamol as a treatment or preventive therapy, as well as a treatment therapy, right? But on the dose that is recommended, right? 1600, that is 16 puffs, right? Leukotriene inhibitors are a beautiful drug group, where leukotriene inhibitors inhibit the cysteine leukotrienes that we discussed earlier, but only in about 50% of the people this is active. This is this is allowed. Leukotriene montelukast is allowed without any restriction. That's the first thing. It can be taken orally, but you have to take it about 4 hours before the event, right? But the important thing is it is effective only on about 50% of the people. Right? So you have to select your patients properly when you're thinking about it. So if a patient is having, tachyphylaxis, risk of tachyphylaxis, it's better to think about starting this drug in that type of patient, right? Mast stabilizers are beautiful drugs, permitted without any restriction, right? They can be taken before the exercise, minimum side effects, but unfortunately, the formulates are not available, right? And we should actually try. The sports community should try to get them, because these are it doesn't cause tachyphylaxis as well, right? So this is a beautiful drug that will benefit our athletes very much if we can bring it down to Sri Lanka if it is produced, right? It's not available in USA as well. Inhale corticosteroids, especially if the patient has asthma, yes, but if the patient doesn't have features of asthma, only bronchoconstriction, the efficacy is not that prominent, right? And anticholinergic agents like ipratropium, in certain groups that I told previously, like the patients who are having increased vagal tone, they will benefit, but some of the patients might not benefit. So this is actually Amy Van Dyken, right? Probably you have heard about her as well, right? He was diagnosed as asthma, and at around age of 6, her doctor suggested that she takes up swimming. Now, imagine the change that the doctor can do, right? Rather than asking her to go and ski or do cross country running, this patient was advised to go and to go for swimming, right? Probably he didn't have probably a scientific knowledge, but anyway, he has got us advised that, and she ended up with an Olympic gold medal in 94 gold medals actually in 96 and 2020. And you know her, right? She has more track and field medals than any other American woman, Jackie Joyner Kersee, again diagnosed as asthma. So what I usually tell my children who come to me and the adolescents who come to me is that sky is the limit. Asthma is not a restriction for your life, for your academic life, as well as your sports life. Even if you want to climb Mount Everest, if you are under control, you can do that. So that is the message that we should give our parents as well, especially who have children and adolescents. But for the elite athletes, we have to also tell them that if you improve your functionality, if you improve your performance, if you identify what is wrong with you properly, then your performance levels will rise. And there are accepted legal methods of improving your enhancement by correctly treating yourself for the underlying disorder. And thank you very much for your time and being present here. And hopefully, we will be having a lot of discussions in the future regarding improving services to our sportsmen and women during and to make Sri Lanka great again, so that we can remember. We can't, you can't just think about 96 and wait, isn't it? We should have another 96. We should have another World Cup. We should have another Susantika, right? We should have another Jayasuriya. Right? So we should strive for performance of our athletes, and we should help them as maximally as possible, as doctors as well. Thank you very much.
Thank you, Dr. Neranjan, for that interesting and very comprehensive lecture. In view of time, I think we can take one question from the audience, from sports medicine colleagues. Anything?
I will leave my email address, and I will leave the presentation, the article about one of articles.
So, if I am to ask a question, Dr. Neranjan, is it correct if I say that the mainstay of treatment for this exercise-induced bronchospasm is salbutamol SOS? Is that? Okay.
Yeah. Provided that is we have to be a little careful there, because according to the GINA guideline also, salbutamol only is not prescribed, because especially patients with asthma. So in Sri Lankan context, before we diagnose pure exercise-induced bronchoconstriction, we have to make every effort to exclude asthma in Sri Lanka, because if we give salbutamol only for a patient who is already having asthma, have increased exacerbation rate, increased penetration. Important thing we have to think about therapy. Now, especially children and adults, what I usually go they have a strong history of family history. Sometimes the child has past history of disease. Then I will urge towards patient having asthma rather than EIB alone. So in allied athletes who have high performance athletes who don't have any history of atopy, asthma, breathing, or anything, yes, I think that should be the standard treatment of option, provided that we have to use it only less than 4 times. But if we take salbutamol and chromoglin, that is item, I would pray that we will get master item, so that we will prevent unnecessary side effects. Yeah. Yeah, masking. Now, that is why I went through that chart. The reason for patients to have hypoxia environment is that they are not humidified up to the natural about 7 to 8%. And humidity is about 50%. By using a mask, we are allowing a different breathing prevent airway hypoxia. But you can understand the difficulty. Can. Yes. The problem is when you breathe through a mask, even when we do small things like doing a clinic, when I see about 70 patients with a mask on, rather difficult. You can't imagine, doing the practices with a mask. So might not be practical. What they say is that you are doing for example, you are going to the dust state. Have your event in about
because of the time constraints, we have to give the whole at 1 o'clock to the other group. So we will wrap it up. But certainly outside, I hope Dr. Neranjan will be able to. We will able to catch Dr. Neranjan and ask you if you have any other questions. But and also with permission of Dr. Neranjan, this will be uploaded to YouTube, our YouTube channel. So everything will be there for you to access freely. So may I kindly call upon our senior consultant physician, Dr. Kirti Kularatna, to hand over the certificate of appreciation.
Handing over the certificate, we congratulate you for the excellent lecture. And it's good that we have taken up that as an interest. I know there are a couple of senior register who just go through the course medicine. They have personal interest in doing the that group is a very group, so together it can do a lot of work here. Full community at least.
Yes. Thank you.
Premla,